and we will discuss, or we will continue the discussions of a clinical chemistry. I will discuss some parts of a clinical chemistry, and you can find my PDF of 21 pages, and I discuss some parts in this PDF, and just cost $1, and you can find it in each video of these parts. So I will continue discussions of the clinical chemistry, and today our topic is purine metabolism. But first we wanted to know what is a purine exactly. So the purine, we know the DNA, and the DNA it composed of the sugar part, nitrogen spaces, and the phosphate group. So focus on the nitrogen spaces. The nitrogen spaces composed of the adenine, guanine, thymine, cytosine. So the adenine and the guanine, they are called purines. So we now know what is a purines: adenine, guanine, which is a part of the nitrogen spaces, and the nitrogen spaces is a part of the DNA, which is composed of the sugar, nitrogen spaces, and phosphate. Let's discuss the first of the purine synthesis. So the purine synthesis, we start off the ribose 5-phosphate. The ribose 5-phosphate, it will turn to the 5-phosphoribosal 1-pyrophosphate, and the enzyme is called PRPP synthetase enzyme. So P-phospho, R-ribosal, P-pyro, P-phosphate. So 5-phosphoribosal 1-pyrophosphate, and we add synthetase enzyme. And this reaction, actually we use ATP to turn it to the AMP. So the first reaction, ribose 5-phosphate by the enzyme which is called 5-phosphoribosal 1-pyrophosphate synthetase enzyme, and that is lead to the formation of 5-phosphoribosal 1-pyrophosphate product. And the other reactions by the glutamine phosphoribosal aminotransferase enzyme. And we know exactly the glutamine and the glutamate, which they are amino acid. The glutamine, which contains the amide group, the glutamate the carboxylic group, because it's acid. So we take the amide group from the glutamine and we added it to the phosphoribosal, and that's why we call them as 5-phosphoribosal amine. So 5-p-phospho are ribosal A amine, and the enzyme is called glutamine phosphoribosal aminotransferase, because we take the amide group from the glutamine and we added it to the phosphoribosal. This is the action of this enzyme, so we call the enzyme glutamine phosphoribosal aminotransferase. And this is the rate limiting enzyme, because we have to know in each reaction, in each cycle, which is the rate limiting enzyme, as we discussed before in the ketone bodies. And then it will go to server reaction till it reach the inosine monophosphate. And these reactions, we use glycine, formyl tetrahydrofolate, glutamine, CO2 aspartate. And to be able to memorize this, we make mimics, which is called go forward and go create an IMP. So G, the first G, go, G glycine, which is the smallest amino acid. Forward is called formyl tetrahydrofolate, and go, another G, it's glutamate, create CO2 and A aspartate. So go forward and go create an IMP, inosine monophosphate. And then the inosine monophosphate formed adenine monophosphate and the guanine monophosphate, and then by subtracting the phosphate, then we can contains the adenine and the guanine, which they are the part of the purines. And if they are increased amount of the guanine monophosphate or adenine monophosphate, like a negative feedback, they are just inhibition, the rate limiting enzyme, which is called glutamine phosphoribosal aminotransferase. Then we talk about the purine sulfase pathway, how it's a breakdown the other reaction that is will be formed, we have three parts actually. We have guanine monophosphate, adenine monophosphate, inosine monophosphate. And as we can see, the inosine monophosphate lead to the inosine, and that is lead to the hypoxanthine. Okay, and by hypoxanthine, that is will lead by the xanthine oxidase to the xanthine, and the xanthine oxidase again, that is lead to the uric acid. And by the guanine monophosphate, guanosine, and the guanosine, that is lead to the guanine, and then the guanine to the xanthine, and then the xanthine oxidase by the help of xanthine oxidase, and that is lead to the formation of the uric acid. So we have to know that the adenine monophosphate has no rules in formations of the uric acid. So we have inosine monophosphate by inosine, hypoxanthine, xanthine, and then the uric acid. Guanine monophosphate, guanosine, guanine, xanthine, and the uric acid. So that is explains why the purine lead to the uric acid. But there is this an enzyme, it's called hypoxanthinic guanine phosphoribosal transferase enzyme, that is lead to hypoxanthine again to the inosine monophosphate, and the guanine again to the guanine monophosphate. So that is avoid the formations of the uric acid. So we can say the hypoxanthinic guanine phosphoribosal transferase is preventing the formation of the uric acid from the purine. The same enzyme, I can say adenine phosphoribosal transferase by the help of the 5-phosphoribosal 1-pyrophosphate, that turning adenosine monophosphate to the adenine. So again, hypoxanthinic guanine phosphoribosal transferase is the enzyme that is preventing the formation of the uric acid from the purine. Purine metabolism, de novo purine synthesis, that's mean each de novo, that's mean a new synthesis of the purine, purine degradation, breakdown, purine salvage, that's mean sorry for that, it's the formations from the old purine, and we discussed the DNA to understand the purine from where. Again, I will discuss that also, that we have ribose 5-phosphate, and then by the help of the 5-phosphoribosal 1-pyrophosphate enzyme, and by the help of the ATP to the AMP, that will create inosine monophosphate. But it's, it's not a lot, and it's not so quickly in that. We can say that the 5-phosphoribosal 1-pyrophosphate by the help of the glutamine phosphoribosal aminotransferase, and by the help of glutamine to the glutamate, and that is lead to the formation of inosine monophosphate dehydrogenase enzyme, that is lead to the adenine monophosphate and the guanine monophosphate, because I didn't mention what this enzyme that is turned into inosine monophosphate into guanine monophosphate, and that is can be happened by the inosine monophosphate dehydrogenase enzyme that turn into the adenine monophosphate and the guanine monophosphate. And then the guanine monophosphate, that is turned to GTP, and the GTP that is turned to the RNA, that lead to the formation of RNA. And you know what is the enzyme here? It's called the transferase, and that is lead to the deoxygenated GTP, that is lead to the formation of the DNA, inosine adenine monophosphate, the formation of the ATP, which lead to the formation of RNA, deoxygenated, that lead to formation of the DNA. But if there is no enzyme like that, so it will turn inosine to the inosine monophosphate to the inosine, and then to the hypoxanthine by the xanthine, inosine to the hypoxanthine, and hypoxanthine to the xanthine by the xanthase oxidase, and xanthine by the xanthase oxidase, that is lead to the uric acid then go to the urine, to the kidney to be eliminated. But we have a disease that is called Leishman syndrome, and that is due to the deficiency or inhibition of hypoxanthinic guanine phosphoribosal transferase, and we said that this enzyme is preventing the formations of the uric acid from the purine by turning the hypoxanthine to the inosine monophosphate, or guanosine to the guanine to the guanosine to the guanine monophosphate. But if there is inhibition of this enzyme, then it will go to the hypoxanthine by the xanthine oxidase to the xanthine, and xanthine oxidase to the uric acid, and the same for the guanosine. So that is lead to the formations of high amount of the uric acid in the blood, because it prevents the recycled of the uric acid. And now we talk about the treatment, how we can treat this subject, how we prevent the uric acid. We have two drugs, iloperidol and fiboxstat, and they causes inhibition of the xanthine oxidase enzyme. So that is preventing the hypoxanthine to the xanthine, or xanthine to the uric acid. So that is prevent the uric acid formation. So by inhibition of the xanthine oxidase enzyme, and we have two drugs like iloperidol and fiboxstat. We have another thing that is causes inhibition of the uric acid, not inhibition of the uric acid formation, but actually increases the elimination of the uric acid, like we making the excreted of the uric acid into the urine, so we can avoid the uric acid accumulation in the blood, and that by using the aspirin. But the question that comes to your mind, which dose of the aspirin we use? Actually, we use the high dose of the aspirin to be able to eliminate the uric acid through the kidney and then to the urine, and we can by this way avoid the accumulation of the uric acid, not by the low dose. If we use the low dose of the aspirin, then we make an inhibition of the elimination of the uric acid. So that's so important to maintain the dose of the aspirin, okay? Because if we give the patient low dose and he has a Lesch-Nyhan syndrome, then it will lead to reverse reaction that we don't want to. So the low dose of the aspirin, actually we uses it as anti-platelet accumulation, like baby aspirin. When we say baby aspirin, because it's small dose of the aspirin, it's 81 milligram, and that is give to prevent the heart attack, and we give it to the old patients. Sometimes we give it to the persons to avoid the colon cancer. So the aspirin in a low dose, we give them to the patients that they maybe they affected in the future by the heart attack, so we give them the low dose, which is 81 milligrams. But the high dose, it acts as anti-inflammatory and not as the anti-platelet. Low dose acts as anti-platelet, the high dose it acts as anti-inflammatory, and we use it to the person that is affected by the gout, okay, because of an increasing of the uric acid. And high doses that help the patient, so that in increasing the elimination of the uric acid, and we use something is called the propenicid. Other thing, we know that the uric acid, the normal values of it is 2 in the female is 2.7 to the 7.3 milligram per deciliters, and for male it's 4 to the 8.5 milligrams to deciliters. So a range in the women is 7, we can approximately it's 7 for the males, for the females, and 8 for the females. These are the normal levels of the uric acid formations. And what is the reasons that is related to increasing the uric acid in the blood? Maybe the first thing is increasing the production, or it reduce the excretion, and we wanted also to know the diseases. So what is increasing the productions of the uric acid? So the first one is ingestion of the purines, like the purines that is present in many foods, and if this person eat so much or drink so much of the food that is contains the purines, then that maybe lead to the uric acid formation, like fructose, like pear, like a seafood. If this person use these or eat these things so much, that is lead to the formations of the purine. And something maybe it's lead to the genetic important error of the metabolism, like Leishman syndrome. And we know that Leishman syndrome, that is due to the genetic disorder is X-linked recessive disease, and it's associated with the inhibition of the enzyme which is called hyposynthetic guanine phosphoribosal transferase enzyme. And something the cancer that is maybe lead to the uric acid, and that is depend what it's the type of the cancer or chemotherapy. Hemolysis sometimes that is lead to the uric acid formation, because that is lead to the degradations, and that is lead to the uric acid formation. Tumor lysis, also the degradation of the tumor also lead to the uric acid, and that is explained why the chemotherapy may be lead to the formation of the uric acid and lysis. So these are the reasons behind why there is an increased productions of the uric acid. The other thing is reduce the excretion, and there are many reasons for that, like like a chronic kidney disease. So there is a problem in the kidney, so it will be not able to excrete the uric acid, or acidosis, because the uric acid is acid, so it need to be alkaline medium to be avoided. So severe acidosis that reduce the excretion of the uric acid. Hyperlipoproteinemia, liver disease. Hypothyroidism, because we know that the hypothyroidism, the thyroid gland, it will be so lazy, every metabolism, everything, it will be reduced, so it will be not able to excrete the uric acid. Volume depletion, and sometimes idiopathic. But what are the reasons that lead to reduce the amount of the uric acid in the blood, which is a good thing? Fanconi syndrome, Wilson syndrome, lead poisoning, and yellow atrophy of the liver, that is reduce the excretions of the uric acid. So that is everything about the purine and everything about the uric acid. Hope you understand anything, and the other lectures or the upcoming lecture, it will be about the urea cycle. So thank you so much for listening.